Good morning, and thank you much. Actually, I've been looking forward to this ever since I listened to Madeleine's talk, and then David's got his in, and the synchrony between the two are really rather extraordinary. So rather than, or different than what we did yesterday when we did two independent talks, I thought it would frankly be more fun to have all three of us on at the same time, because actually there's a joke, the joke would be, what happens when an intensivist, an anthropologist, and a computer scientist walk into a bar? The answer, of course, is we can't for at least another 6 to 9 months, but we'll get there eventually. That's right. And yes, we're all drinking coffee at the moment, which is the only appropriate. I'm assuming that's what's in your cup. Anyway, regardless, the goal this morning is Madeleine, Clare, Elish has got her talk up on YouTube, and I would highly encourage people to take a look at it, and takes a unique perspective on the anthropology of getting this computer science work in at the bedside at the team level. And what David Sontag has done is taken also in a YouTube that I would highly recommend, has done is taken a very difficult problem and basically come up with an, oh my, it's almost a Houston, we have a problem type of thing. So what I want to do is put out a hypothetical, and it would start with Mark Zuckerberg's, and I have no idea if this came from his mouth or someone gave it, but Zuckerberg's line of move fast and break things. And I'm a complete fan of that, because as a clinician at the bedside, I can rail for hours and have in editorials in print that the system is broken and needs to be broken again and put back together one more time. But having said that, it needs to be done in a safe and coherent fashion. So let's pretend, and I'll start with Madeleine first, but let's do a hypothetical scenario and say, okay, some company has put out a diagnostic algorithm and a therapeutic one for simple urinary tract infections, as David as David worked up in his talk. And because the group that put this out and the company that picked it up isn't as compulsive as David's group is, it went out too soon. But nonetheless, there's a physician champion in hospital X someplace, and they've implemented this. And I'm going to throw it to Madeleine first and say, okay, so talk to us about the labor involved in supporting something that doesn't quite work. And Madeleine, if you want to jump in and even do a review, do a 3 or 4 minute overview. Why don't you start with that? A 3 or 4 minute overview of your points from your talk.
Yeah, so actually in the report that this talk is based on, stay tuned next month, we actually use the phrase of, Zuckerberg's or whoever's, move fast and break things, around this idea of a lot of the times when we look at innovation, we look at it precisely to be disruptive, to change things up. And like you're saying, to break broken systems again, which is great. It often, though, means that a lot of things get disrupted, and that's where we get this term of repair that's in the title of the talk. Is that even when a system works even if a system isn't sort of working incorrectly the way that you set up this hypothetical example, there is going to be a lot of labor in the clinical practice to integrate this new technology into existing workflows. So one way also, I like metaphors. I like sort of changing the way words can help us think about things. I think one of the clearest ways to think about this distinction is actually the difference between deploying a technology and integrating a technology. So actually, generally, we talk about deployment, right? We're going to deploy this tool. But deploy is actually, when you think about it, it's like a military-derived term. Deploy is like a contextless dropping in. And in fact, especially in high stakes settings like healthcare, you can't just like drop and go, right? You have to integrate the tool into the local practices. And when you say the word integrate, it sort of makes you, answer the question of integrate into what or with whom. And so in the case of this hypothetical example that you gave, I would say that the company deploying it was really thinking about deploying it, right? They built it up and then they were like, here, and pushed it into the clinician's hands, which I think is a pretty irresponsible develop technologies. Because what I'm saying is, not like brilliant and earth-shattering. There's a lot of social science that, especially also in the healthcare field, that tells us that there is a lot of local context that matters when you're going to create a new way of doing things. So that's sort of a very broad overview. And so I guess what I would say, and when we were talking about this question, before the panel, sort of what are some anthropological, what are some guardrails we might put around integrating this tool? I would actually say if it has already sort of left the development site, in many ways, it's sort of too late. And I would rather, focus on what should be done before pushing something out into the world where it can be misused or used in ways that are not actually going to be effective, right? Which is precisely what David's talk was about. And so I really, one thing, and then I'll pause, one thing that I really appreciated about the work that I got to be involved in at Duke with the project that I talk about called Sepsis Watch, developed by the Duke Institute for Health Innovation. Huge shout out to Mark Sendek, Suresh Balu, Will Ratliff, and lots of other people in this community who developed the tool. Is the need to work really closely with clinicians, and it seems like, David, precisely in the work that you're talking about, there was a lot of back and forth with the labs, with the clinicians, sort of using those experts as a way to understand the context of the hospital. Context is not something you can think your way into. You have to go and talk to the people who are experts in that context.
All right, well, that's actually a great segue into where David's talk went. I have one very specific question that you can just work into response. I want to know who it was that said, oh my, which is probably not what they said, but I'm being polite. Oh my, we have a problem here, and who had the courage to run that one up the chain. But still, David, why don't you do a riff on the work that you've done and put it into this context of integration, actually. We'll go with that word. I like that word.
Well, first, Jim and the organizers, thank you so much for having me at this conference. And Madeleine, it was a pure pleasure watching your talk and learning from the way that you're framing the distinction between deployment and integration, which I plan to use in all of my future talks as well now. So I'll start by giving sort of a very quick overview of what I spoke about in my YouTube video, which I encourage all to see if they haven't yet. I gave a case study of work that my group has been doing for the last 3 years on prescribing antibiotics, in particular, how one can recommend treatments for uncomplicated urinary tract infection. This is work that got started when an infectious disease clinician from Mass General Hospital, Sanjat Kanjilal, asked me, could I join your lab and work half time in your lab in bringing machine learning into my area of expertise, into his area of expertise. And that was over 3 years ago. And he spent 2 years in my lab building up this project together. And we had 2 phenomenal master students, Helen and Suraj, and a PhD student, Michael Oberst, who really led this work from ground up together with Sanjat. The high-level question which really intrigued me when we began was that I, having done a lot of work previously on more diagnostic flavored questions in machine learning, had only been tackling the treatment recommendation side from a theoretical angle up until now. So I had done a lot of work on how does one use causal inference and observational data to figure out when a treatment would be effective and for whom. But there seemed to have been a big bridge between that theory and actually trying to use those in practice in the whole entire community. And what really attracted me about this problem of antibiotic prescribing is that first of all, it was easy. So there were not hard causal inference questions to tackle because we received from the hospital antibiotic susceptibility results delayed, about a week or 2 delayed. We would receive the results of what would have happened had a different antibiotic been given, because those were tested in the lab. And the second reason which really brought me into this problem is that we were able to find something which I thought was relatively low risk to study. So we focused on uncomplicated urinary tract infection for first the reason that if our algorithms screw up, then it's not the end of the world per se. It's a medium stakes setting, not a very high stakes setting, and that's exactly the type of setting which I want to start doing research in this area on. The second reason why it was so interesting to focus on this is because we were able to really think, how could one do a retrospective evaluation? So when one does retrospective evaluations for example, diagnostic related problems, usually it's very easy to know the ground truth of, well, what is the underlying diagnosis and how far off are you from that? And then there are lots of really essential questions, both about doing error analysis and then really thinking about how one would integrate that into clinical scenarios, to use Madeleine's words. But from a treatment recommendation perspective, it's been really the wild, wild west in terms of thinking through, okay, how would one properly evaluate a treatment recommendation algorithm where you might want to, for example, compare to existing clinical practice? And how does one do an apples to apples comparison of that sort? And so what I view as our biggest contributions has been to methodologically tackle that problem of how one could do that evaluation. And we introduced this idea that I spoke about of the target deployment, where one thinks through very rigorously what is the clinical scenario in which you plan to deploy that treatment recommendation algorithm, thinking through many of the questions that Madeleine talked about in terms of how would it be integrated into the clinical workflow, and then try to carry that back as much as possible to the machine learning part of the problem, where one frames both what is it that you're predicting and how are you evaluating it to try to mimic as close as possible that downstream integration that's going to happen at some point in the future. So that's what I spoke about. And what Jim was alluding to at the very beginning was work that, this was a 3-year-long project. At 2 different points during this project, first in the first year and then a second time in the 3rd year, we discovered major errors in our analysis. And I spoke about those errors, which I said in the talk were embarrassing to us and our team, but we think are really important to write about and to talk about, because it's the same sorts of errors that I am sure everyone else is making as well, and we need to start to understand how these can happen. So Jim, let me tell you now, to answer your question, sort of how do we recognize that we had mistakes in our analysis? Well, I'll go a step further and tell you when the second mistake was found. It was found after our paper on the subject was basically accepted to a #1 medical journal. So we were, we received, basically, we were making the final edits, getting it ready for camera ready, when in doing some of our follow-up work, which was for a second publication, we found a problem. And so immediately we withdrew the paper from consideration. It's after resolving the errors, it's now under review and hopefully will be published soon. But that's scary. It's a situation which you both never want to be in as a PI, but also we got lucky in that it happened right before it got published. So we were able to withdraw it without too much concern. And how did it happen? How did we catch this error? Well, the only way in which we were able to catch it was by really trying to understand what our models were doing. So we did some introspection into our models to try to understand why was it making recommendations one way or another. And we told a good story about it. As I said, the paper was basically accepted for publication because the features that seemed predictive, it made sense. We could justify it. But we wanted to understand it better. And so over the subsequent few months, we dug deeper and deeper and deeper, and in particular kept trying to simplify the policy as much as possible, because we wanted to think through not integration, but deployment. So Madeleine, in your talk, you said cross out deployment, talk about integration, but actually I would argue you need to have both parts of the story. So in my talk, I spoke about the deployment part. I didn't talk about the integration part, but actually we have a lot of work there and I had a lot of things to say about it. It's just in 30 minutes, we couldn't get to it. But for the deployment aspect of it, which is how do you actually get it into clinical practice, the simpler your model is, the better. Because even just from a software engineering perspective, it makes your life easier. So we were simplifying it because we wanted to make it broadly deployable. And at that stage of trying to understand and simplify, did we really catch the error? And who brought it up the chain? Well, my students. So this is one of the things that I really pride my students in, which is that they spend the time to really understand what they're doing, to dig deep, and to try our hardest to make sure that what we're doing is clinically relevant. And it's in that process that we can find such things.
Yeah, no, it's spectacular. I am a fan of your lab, all for that reason, actually. One of the questions, actually a couple of questions have come in, and they're easily, a couple of them on the same topic, and to integrate them. Whose job is it? So, David, you just talked about simplifying the models and getting deeper and deeper into understanding them. And that's one thread. But then, Madeleine, in the hospital, as near as I can tell, it's no one's job to do the integration piece. Should that, and it's one thing to put a model up in an academic environment where all the development's been done there and everybody knows the developers and there's all sorts of internal credibility. But if we're really going to broaden this and commercialize it and move it from one site to 100 sites, do we need a whole new job role? And does this need to just become a part of the cost of doing business, of trying to get these algorithms into widespread use? Sorry, too many questions all at once.
In short, yeah, no, I know. I'm going to tease out one of them, and I'm going to try and loop back into David's point about, I would agree that, deployment and thinking about what it takes to deploy something is there are useful delineations about what's at stake. And so we can talk about whether a goal is to develop and deploy, and then deploy is not the end of the line in some ways, right? We would have to say integrate comes next. So for me, in the slide, I cross it out because I think often if we do want to think about an effective intervention, it has to go to that next integration step. But having these different words can help us talk about different pieces of the development cycle. And so that, so yeah, I think that can be useful. So Jim, to then get to your point about, is there anyone whose job it is? For those who didn't see the talk, the case study that I discussed is a machine learning driven model that was integrated into a hospital care setting to support care for and diagnosis of patients who are at risk of developing sepsis. And what our research sort of brought to the surface was that nurses were playing an incredibly foundational and often unexpected role in actually allowing this ML-driven system to be effective. And so I would say that, you know, for me, there's the, you know, whose job it is. That's, I think it is always going to be someone's job, first of all. And so for me, the sort of, there's even a political project here, which is that, you know, the work of computer science, typically male and elite, is seen as the real driver of innovation and change. And in fact, when we think about all of the stages and we think about this idea of integration, nurses who are typically female population and culture, of course not exclusively, right, but a lot of nursing work is seen as gendered work, it is less well paid work. There are actually like political stakes in saying not only whose job it is, but how can we elevate that role of integration as like not a kind of a backup kind of invisible labor, but as something that is key to integration and key to like an effective intervention. And so yeah, I think it is going to be someone's job, and the more we acknowledge it, the more we can allocate resources to it, because this is also a question of resources, right? Hospitals are of course ready to support new technologies. It's actually harder to mobilize resources for like more nursing staff.
Right.
But if we see such nurses or such integrators as not like, oh, nice to have, but as essential, I think that's the future of AI in healthcare and AI in the workforce, right, that I want to, you know, be part of creating.
Could I?
Go, David, please.
So it might be helpful for us to distinguish between the process of planning for integration and actually doing the integration. And when one thinks about sort of whose job is it, the planning for integration, as Madeleine suggested in her talk, and as I've seen in my work, has to happen from the very beginning. So when one's designing what is the precise machine learning problem you're going to formalize and then run your algorithms on, you have to be thinking through the full end-to-end to how would it be integrated into clinical practice already at that stage. And so that idea has really guided the way that I have tackled problems in healthcare. So for example, my work going now over 10 years with Dr. Stephen Horing at Bethesda Deaconess Medical Center has tremendously benefited from his ability to think through that integration step at day one before we get started with any data. So that can only be done because, I think it's done effectively, we'll say, because he has a training in computer science from his undergrad degree, and he is an emergency medicine physician. And so he has a very good understanding of the workflows, understanding of who are the different parties of which would have to be involved, just analogously to Madeleine's comment about there being separate nurses, and the nurses have to communicate with the emergency medicine doctors, and that there being tensions there sometimes. Those are things that as a domain expert he would know about, and that would then inform which problems we tackle and how we tackle them. So I'd say that has to be the very beginning, even before you're thinking about whose job it is towards the end of actually executing on that plan. I have some other things to say, but I'll pause there.
So,
can I just also
yeah,
add one quick thing to that? And I think you're absolutely right. It has to start from the very beginning. But I think also it's an iterative process, right? So the Duke Institute for Health Innovation team, also incredible collaboration from the very beginning, not only with physician leads, but also with nursing leads. But it actually there were new things that happened that no one could have anticipated, even though they knew all of these, pieces of the clinical puzzle. So it's not kind of a one and done, but it's like
Well, so, okay, good. In fact, that's a perfect segue into the next place I want to go. So the notion of iteration, I think, is crucial. It's iterative both on the anthropological side, but it's also iterative on the computer science side. And I'm nodding left to right because that's the way you guys are on my screen. David, so when you took your model from nearly 1,000 features down to a dozen or 24, and whatever the final number was that, how did you iterate that, and what thought processes? And the two that I see most obvious are obviously straight computer science feature statistical significance, but there's also the practical problem of, are they really available widespread in the EMR? So I'm curious how you went from 900 to a couple dozen.
In that particular case, the features that we started with from the beginning were already designed to be readily available in the EMR. So even the 900 features that the original policy used were conceivably fair game for implementation and widespread implementation. And in that work, the cutting down of features was very much data driven, not driven by the sort of ease of implementation. The ease of implementation questions were tackled much earlier upstream. So for example, when we first began the work, we were using all of clinical notes as features. So this is data that was from Mass General Hospital and from Brigham and Women's Hospital, and we had all notes written by every clinician up until the time of which an empiric antibiotic prescription would have to be made. And we conjectured that there would be important information in those notes about, for example, chronic conditions or past antibiotic prescribing practices that might be predictive of how a patient would respond to antibiotics today. And so we used those as features. But very early on in the first couple of months, we realized that we could get rid of that information. So we found a couple of things we found a couple of predictive features in those clinical notes, which by introspecting into the model, we realized would be important for making good predictions. But then we were actually able to derive that relevant data from structured information. So we discovered it using clinical text, but then we got rid of the text altogether and found the relevant structured data for it. And so that's where that step happened.
Got it. And iterating on the anthropology side, sorry. So it sounds like we really should embed somebody in many of these early deployments, looking for this hidden work. And I guess, it's almost not a question as much as I agree with you. What skill sets do we need? What skill sets do people need? And where do we find such people? Is there anybody but you?
There's so many other people besides me.
Yeah, good.
I actually sort of feel like this conversation is beautifully iterative, because actually David was one of the first people from the machine learning for healthcare community that I first really met like many years ago. Right, David? in New York. We are both now, going to be in different jobs. He has been already, and it was like
Congratulations, by the way, on
early
the new job.
conversation. Oh, thank you. He was like a first person where I was like, so, healthcare, like, how can we be thinking about, like, what does it mean to do machine learning in healthcare ethically? What are the sort of social implications, all this stuff. And, since then, the world of people thinking about this has grown so immensely, and it's really amazing. I'm so sad not to sort of get the chance to meet everyone in person. And also anthropologists just like really love hanging out at conferences. It's a great field play. So I don't want to talk myself out of a job, but I also want to say that, anthropologists are great because we go through a lot of training and research about what are some analytical tools to think through something like invisible labor or kind of unexpected or actually expected social implications, because we also study a lot of history, and a lot of issues that we're coming across are not new. They're rhyming with the past, but there are also a lot of local experts who would be able to tell you what is happening. I mean, the way that I really got to see all of the work that the nurses were doing was because they told me about it, right? I was there to listen, and that's absolutely important.
Right.
But, especially if it's something this was clinician focused. And so important to think about not just the most high status clinicians, but also some of the lower status clinicians. And if there's something that is aimed at patients or different patient communities, I think really figuring out, like, you don't just need to find a social scientist. You can also, first of all, you can always, collaborate, and lots of people in everyone's universities, they're out there, their whole departments, but also figuring out how to really practice some like community-centered design principles, which is something where there's, again, a whole really exciting literature.
I wanted to jump in here as well, which is that, so as I was watching your talk, Madeleine, I kept thinking back to some of the things that my group had done in the past, and many of the things that you've done, we do as part of our typical workflow. What I view is really important about your job and your role is framing it correctly for us and putting academic rigor into how this should be done. And so, Jim, my answer to your question, I'd love to hear Madeleine's comment to this, is that, if Madeleine is successful, she will become redundant at some point. So by doing this research, by making it systematized, all of our students, all of our who then graduate and go into industry, will be doing this as part of their development cycle.
Right. No, perfect. And in fact, in very large part, that's why many years ago we put this conference together to frankly have conversations just like these. So we've got clinicians, anthropologists, and computer scientists all on a single screen.
Yeah, actually, I want to change one thing I said. It won't just be the computer science students, right? It's the full team that would be doing this. Yes,
I'm with you 100%.
Yeah. So again, thinking about like what is the future of, like, again, AI, using AI, in its expansive and very general meaning, like, what is the future of data-driven technology development? It should include not just computer scientists, right? It should include local community experts. It should also include social scientists, historians, or empirically trained. I think that collaboration makes everything strong. Like, I have learned so much from the Duke collaborators, and I like to think that I've been useful not just in this project but in future projects. and that's just the beginning. So I think figuring out how to have interdisciplinary teams, which is actually really quite difficult, is something that is a great goal for everyone. Because also this is, I would say that, anthropology and other social sciences in particular are very individual focused in a way that a lot of computer science or engineering labs are not. Anthropologists aren't necessarily used to collaborating. And so I would also say that, like, to other anthropologists or social scientists in the audience, that's a skill that I have had to develop, and that I think we have to develop as well, is to sort of how to fit into a group where the project is greater than the sum of our own specific contributions.
Brilliant, exactly right. Let me ask a couple of questions from the audience that will require me to put out a personal disclaimer that my son knew more math in the 8th grade than I know now. And David probably knew more in the 4th grade. So one of the questions that's coming through is, so in the UTI work that you did, you used time frames to split the data. Talk for a second about the splitting between doing a random. What would have happened had you done a random, just taken all the data as one big set and trained on 2/3 and tested on a letter third, or basically did a random split rather than a time series split? Would that had, so sorry, I'll stop there.
So I think it's generally good practice to hold out data of this sort, just like it's good practice to do multi-institutional generalization studies. In fact, had we designed our study different from the very beginning to, for example, train just on Brigham and Women's Hospital and then evaluate on Mass General Hospital, we might have recognized some of the problems earlier than we actually did. But that wasn't part of our original design. And so I'd say one of the real benefits of designs of this sort, where you would, for example, hold out future data like 2014, 2016 for evaluation, not train on that, is that it can help identify either mistakes in your analysis, or it can help identify some brittleness of your models, which would not when they might not generalize to particular data set shift. And data set shift is so commonplace in healthcare, whether it be due to, for example, the populations changing across time. Like now, if we were to look at data from the last few months, it would look tremendously different because there is a new condition, COVID-19, that didn't exist in the data before, because patients are not going to the doctors, the offices, they're largely doing telemedicine. And so your predictive model was trained on data from a few years ago, from a few months ago even, wouldn't work at all well now, today. And so being able to catch that is an important part of the development process.
So let me, and I get it, the Brigham and the MGH are both spectacular facilities. Suppose one place really did a better job with UTIs, or, pick a disease, whatever it is. And is there a way to look at the data and say, maybe hospital A ought to be doing something more like hospital B, or C or D? Yeah. And again, as we get deeper and deeper into deployments.
I mean, so one of the things that we do in our analyses are trying to understand clinical decision making, because by understanding it, it's both a sanity checking tool to see what's the information that they might be using, and do our algorithms have access to it, and it's also a debugging tool. In fact, one of the ways in which we discovered our latest, the second error that I talked about in my talk, was by seeing, once we simplified the policy so tremendously, we saw, or thought we saw, that physicians in one of the hospitals are performing significantly better than physicians in the other hospital. And so it was by looking, and that really surprised us. And so then we found the data error, which then our machine learning algorithms were also susceptible to. So I think it's useful. I just want to mention a second thing, which is more broadly this question of trying to do introspection into clinical practice and variation is, I think, a really important research direction and something we're actively working on now, because often the often the proper integration of
think about it.
of machine learning insights into clinical practice won't be by actually deploying a machine learning into clinical practice. In many cases, I conjecture it's going to be by changing clinical practice in very non-technical ways. And so one of the things that my lab is really doubling down on right now are algorithms that can identify practice variation. And then we're, for example, working with health insurers. Those health insurers have huge incentives to then go talk to those big practices and talk about standardizing or improving that practice, getting rid of some of the variation when it might actually impact outcomes.
Okay, so that's a segue into a question that just came in. You know, there is a field, and there's books on change management, and so to get physicians to buy into this, and by this I mean, frankly, any new technology, just ML and AI more broadly. Are there techniques other than just waiting for the people of my age group to retire to do a better job of getting clinicians to buy into this, or not even necessarily buy in, but to accept the advice from a machine? That sounds like a question for an anthropologist.
I mean, I would say, you know, I would love to hear David's response, because David has many more years working with clinicians than I do. I want to quickly bracket this question and just offer one resource for the community, because I really like what David just said about, like, where is the role for a machine learning intervention, and maybe it isn't right at the bedside, maybe it's in, you know, other parts of the system. There's a really, really fabulous paper by Rediat Abibi and a company called Roles for Computing and Social Change, which I think is a really nice sort of theoretical, grounded in examples way to think about, you know, how can we think about where computer science driven interventions are appropriate and where are they not? And how can we sort of double down on thinking about how they can help spot issues the way that, you know, some of David's labs and lots of others do, and not try and have machine learning projects be everything for everyone all the time. And so I guess to tie that into this question about how can we get doctors to trust this stuff, I would say doctors and nurses and other clinicians.
Oh, yeah, no, 100% right. My, frankly, apologies. Go ahead, keep going.
Yeah, no. Just, I mean, it's just making explicit what we all know implicitly, right? But just making it explicit helps keep it on the surface. Is I think in many ways thinking about these collaborations. Listen, we all know we want to be a part of a project. We're happy to take on something that we feel like we have some part in, right? Some sort of ownership over. And so thinking about how can tools be developed collaboratively, integrate, like in planning for integration from the beginning, not just deployment. And I mean, this is an area that I want to continue to research and study on, because I don't have a lot of specific research of my own to draw on in this regard. But, you know, this is also something that we wrote about in a FASTSTAR paper last year, was even some of these issues around, well, if you know, algorithm is explainable, will doctors trust it more? Maybe, maybe not, right? I think that there isn't one straight answer. It's actually about, again, like how can it fit into an existing social process, an existing clinical practice, and not just be parachuted in.
So David, we're running up. Frankly, the time has flown by here. We're into our last couple of minutes. You've been doing this for a long time. Do you see the clinicians, regardless of what role they've got, are you getting more? Over time, how has your collaboration with clinicians changed, if at all?
So I've been very fortunate to have some amazing clinical collaborators, and you know, as I mentioned, one of them I've been working with since the very start of my getting into this area over 10 years ago. I'd say the interest in machine learning in healthcare has exploded, not just from the general public, but from the clinical community. I teach a class called Machine Learning for Healthcare at MIT. I've taught already 3 years, and there's broad interest from clinical community, not just for sort of participating, but also for being mentors in the class. We had 20 clinical mentors from the Boston area this last semester. In addition, I conjecture that there's broader interest as well. And so one of the things that Peter Solovitz and I are doing are preparing an MITx class that's going to be available for free on edX based on our MIT subject. We think that there's quite a bit of demand for getting into the area in this way. And I think also, and others here know much more about this than I do, but I do think that there's going to be changes that are going to have to be made in medical curriculum that will support this.
Sorry. All right. So actually, questions are coming in that we're just not going to be able to get to. Madeleine and David, and my thanks to you both. I learned a lot. I would push people to listen to your talks and just keep these collaborations alive. I think this was utterly spectacular.